Assalamu alaikum student. We have started abnormal labor in which we have discussed about the cephalopelvic disproportion and the poor progress in the second stage of labor. Now we are going to discuss about the management of the cephalopelvic disproportion. We have to admit the patient, we have to monitor the BP, pulse, temperature, because the fever will be raised, pulse rate will be high, the female will be tachycardic, and there will be acidotic breathing in the CPD, and BP will be BP will be low. So we have to pass the IV line, we have to pass the IV line, and we have to give IV fluid to treat dehydration and to prevent acidosis. We have to rehydrate the patient to prevent acidosis and to treat dehydration. We have to catheterize the patient to measure the input and output record. We have to catheterize the patient. We have to monitor the vitals, and then we have to give prophylactic antibiotics. We have to give antipyretic like paracetamol. We have to monitor the patient for shock, for the complication like shock and acute renal failure. And the mode of delivery, the delivery will depend upon the cause, the progress of the labor. If the cause is dysfunctional uterine activity, which we have already discussed, if the cause is primary dysfunctional uterine activity, then we will do artificial rupture of membrane and will be followed by oxytocin contraction. If the contractions, oxytocin infusion. If the uterine contraction are very poor, then we will give oxytocin infusion. First we have to do artificial rupture of membrane, then we have to do oxytocin infusion, and then we will perform instrumental delivery or vaginal delivery. But we can perform vaginal delivery if the cervix is fully dilated. If the cervix is fully dilated, then we can perform instrumental vaginal delivery, as well as if the CTG is abnormal. If the CTG is abnormal, it means that fetus is in compromise, that fetus is in compromise. So in this case, if the CTG is abnormal, we have to deliver the baby by instrumental delivery. And if the progress still fail to occur, then we will and the fetal is still in this distress, all of the if instead of oxytocin and artificial rupture of membrane, if the progress still fail to occur, and instead of using instrument, if the progress still fail to occur and the fetal is in distress, we will go to C-section. Thank you. This was all about the management of the cephalopelvic disproportion.